Hi, everyone. Thanks so much for joining us today for the Healthy 100 web chat. We're taking on a topic that so many people can relate to. Headaches and migraines, something a lot of people have. We've got a great doctor in to talk to you today through some of these different types of head issues and what this head pain can mean. Dr. Ros-Escalante, he's a neurologist here at Florida Hospital, is here to take your questions. So we're having a little bit of technical difficulty with our web chat today. So if you could tweet us your questions, or if you want to email them to us, there'll be directions for you to do that on your screen throughout the chat. We'll try to get to as many of those as we can in the next 20 minutes. Well, the doctor is in, so let's get things started. Welcome to Dr. Ros-Escalante. Thanks so much for joining us today.
Thank you for having me.
Yeah, absolutely. So let's get right down to the nitty-gritty. There's a lot of different varieties of headaches and different kinds of head pain out there, but what is the most common cause of a headache?
Well, first of all, trying to understand how is that pain is, perceived in the head, the structures that are involved. It's important to understand the nerves and the areas that receive the sensation at times can be sort of vague, and they will be associated with injuries or inflammation, traction, compression of structures that are pain sensitive. This will include vessels inside of the head, large vessels in particular, sometimes the proximal aspect of medium-sized vessels, as well venous sinuses. All these are the vasculature inside of the head. This structure will be perceived through particular cranial nerves. In addition to that, scalp, face, teeth, jaw, neck can also be areas that could be injured and also send signals of pain to the brain. Yeah. Headaches can be from any process affecting these structures. At the same time, can also be from the system itself that might be injured. In those cases, we call them neuralgias. So those would be sort of the areas that need to be affected to cause pain in the head. Headaches can be benign, and at times can be not so much, benign. Primary headaches tend to be syndromes in where we don't identify anything that is stimulating these sensitive areas, pain-sensitive areas. At other times, the concerning ones will be if there is something affecting these areas, such as from benign things, inflammation, up to more ominous etiologies such as tumors or blood.
Right. But it's not, you can't jump to that conclusion if you have headaches, right, frequently.
Correct.
This is not necessarily, oh my gosh, I have a tumor. I know some people get a little bit of hypochondriac about them, but, talk about, we're going to kind of get to those more severe things as we kind of go through this, but let's stick with the headaches for a minute. What are some of the ways that you can prevent getting the garden variety headache that, a lot of us experience
Right. If we have this sporadic headaches that don't have any negative symptoms with them, and we don't feel that we need to seek medical care for them, sometimes, just simple things that are not even medication can be helpful. I do tend to express to my patients to use common things, sometimes massages, relaxation techniques, yoga, sort of biofeedback processes can also be helpful. These are not, they're no medications, and as always, the rule is that the less medication we administer, the better, So these things can at times be what the patient needs, rather than going into medications.
Right. I mean, simple things. I know the kind of headache that plagues me, and I don't even know if this is real, but I think of them as dehydration headaches. I know if I haven't had enough water, my head starts to hurt. If I can just down a big glass of water, I can kind of get through it without having to go to the medication.
Correct. I mean, as simple as sometimes people get used to certain doses of caffeine, and not having your daily caffeine can be a trigger for your headache. So knowing those things can empower you to be able to control them without necessarily having to take medications.
Right. Some of the basic things too. I know things like sleep and sleep play a big factor for people with headache.
Sleep deprivation is a big factor, and it can be associated with sleep disorders as well. But at times it can be just that not getting our natural, normal 7-8 hours of sleep can put you at risk to have headaches.
Another thing that I wasn't aware of was posture, and how can that impact your head?
Yeah, many people, you know, the way we work, we sit down in a desk sometimes, and you know, not having the right posture for a prolonged period of time, stress at the neck, stress at the lower back, can be simple things that can be triggering headaches.
Yeah.
So being aware of that and maybe trying to adjust our environment where we work can prevent, you know, the sporadic normal headaches.
Sure, sure. What are when is somebody going to go, okay, we've been talking about the garden variety, stuff you can handle with over-the-counter medications or not even medication at all.
No.
When is it time to go see somebody about a headache or a reoccurring headache?
Correct. So anytime there are focal deficits associated with a headache, if at any point you have weakness, sensory loss, or positive sensory symptoms, paresthesias in parts of your body, visual loss, positive visual phenomena, lights, and when we have nausea, vomiting associated with a headache, neck pain, stiffness, fevers, those are not common for the sporadic headache, and those should definitely trigger a further evaluation. If there's trauma associated with headaches as well, further evaluation should ensue.
Yeah, and so certainly there's a lot of some of the symptoms you described, the vomiting, the lights, the sensitivity to light. Some of those are what I've heard people talk about when they experience a migraine.
Correct.
So what is the difference between that migraine versus a headache, and when you know you've got one versus the other?
Correct. People who have migraines tend to have them early in their lives, so they learn early on how the headaches are. So they have the symptoms at times, and having them always the same is not necessarily a worrisome manifestation. They might need medical care, but not necessarily visiting an emergency room. Maybe just, you know, seeing their primary care doctor or visiting a neurologist. So we can maybe provide some pharmacotherapy alternatives to them. But some of the more negative symptoms certainly should require further evaluation. In that case, potentially even an emergency room visit. But I tend to tell patients about positive symptoms and negative symptoms. When you have positive symptoms, meaning bright lights, colors, paresthesias, meaning tingling sensations that are associated with your headaches, and you know this is what you always get with your headaches, that shouldn't trigger a immediate emergency room visit. But when you have negative symptoms, those are not common for simple sporadic headaches or even primary headaches of the migraine type. And those are the loss of vision, weakness, numbness, the neck pain. Those things certainly need to be evaluated, not even in an office, but in the emergency room.
Wow, okay. So thinking about those things, I guess kind of the general rule, it sounds like you're saying, is that when it's not just contained to the head and it's affecting other parts of the body, that's when it's time to get that medical attention.
Correct,
maybe.
correct. I mean, if the headaches are disabling, persistent, those things as well should be considered significant, and they should be evaluated further.
Great. Tell me, what are some of the things that you can do? A lot of people complain about those migraines, and there's different types out there. Is there a way you can prevent them?
Out of the primary headache syndromes, migraine is the most common one. There's some other types of headaches that are considered primary, and when I say primary, I mean there's nothing structural or inflammatory causing this headache. They're just there's nothing but just a mechanism of vascular dilation, we say, that affects the headaches. And the things that can be done to prevent them go from very simple things, you know, learning what things you do and triggers you might have for your headaches, and trying to avoiding them. If these things are not enough, or in addition to that, potentially medication can be offered. We can go from very simple therapies as over-the-counter agents, non-steroidal agents such as Motrin, Aleve, Tylenol, things like that. And at times medication specific for migraines can be offered, as well specific for the other type of primary headaches, tension headaches, cluster headaches. And there's a large armamentarium of medication that can be offered to stop headaches as well as to prevent them. We use a 2 headaches in a week sort of cutoff to determine if somebody's going to receive preventive therapy, meaning medication every day, versus medication only when you have a headache. And there are various agents that can be used for one or the other.
I know there may be some questions coming in. We'd encourage everybody to kind of use Twitter. Our chat role is not working today, but you can email us questions. You can also tweet us questions. So if you have any questions, we'd love to try and get those to Dr. Ros-Escalante in the next few minutes as we kind of go through the chat here. You know, we talked about some of the bigger issues with headaches. Tumors, and some people, you know, talk about epilepsy and headaches, but what can headaches be a sign of a bigger problem? Is that something that people need to consider?
Absolutely, absolutely. It is sometimes difficult to throw a line into if this is a benign headache or not, okay? If you're in doubt, I would suggest always err on the safe side of being evaluated. Potentially just discussing it with your primary care physician might be enough, and he might be able to shine some light into if you need further evaluation or even a referral to a neurologist. Some of the things that can be, we discussed already some of the things that can be associated with a more ominous headache. And we can go from, as you just say, tumors, focal lesions, bleeds, things that you know, can be a cause for secondary headaches. And those are the ones that need further evaluation. When you see somebody in the office, the potential things that we do are, besides some laboratory testing, imaging. Imaging is critical in determining the nature of a headache. We have CT capabilities, MRIs. MRI will be the ideal study. It's the most sensitive one to identify if there's any of those things that might not be so good. So we can do those things to evaluate further.
Yeah, and I know we are getting some questions from the audience. Want to make sure we take an opportunity to answer those. One of them that's coming in is about headache, and how do you fix a headache from, you know, enjoying, you know, sometimes things can bring on headaches, like sometimes you have a hangover headache, sometimes those kind of things. What are the best ways to kind of handle that kind of thing?
Well, it's known that, for example, medications and at times even alcohol can be associated with headache. Those are the things that we can control. Sometimes people suffer from headaches, and there's little that they can do to change that, but there are things that can control, such as smoking, alcohol, coffee intake. Those things are in our hands, that we can, if we identify those things being triggers, we could maybe adjust. You know, alcohol, it is a known cause for headaches, as well as the withdrawal from alcohol also can cause headaches.
Yeah, so something to keep definitely in moderation. The less you've got of that going on, the less chance it's going to cause headache.
Some common sense in that, yeah.
Yeah, absolutely, totally makes sense. You know, some of those bigger problems, epilepsy comes into the picture, and I know that's something that your team works with quite a bit. Talk about, for those who may not, this might be a new realm for them, what is epilepsy? What's going on in the brain with that?
Right. Well, I mean, headaches can be, as we say already, from focal lesions, and focal lesions in the brain can at times be associated with seizures. Seizures or convulsions are when there's hyperexcitability of the cortex of our brain, meaning the brain discharges all at once, and that's how we have full activation of our body, and we have this typical posturing and clenching of our teeth and loss of consciousness. The brain no longer is working.
Yeah.
Or is better say working all at the same time, and right after that we go into a decreased activity. And seizures that can be from focal lesions can also be associated with headaches.
Right. So tell me a little bit about those. Obviously, they're very scary symptoms when people either witness them or experience them. Obviously, people are very concerned, you know, worried in a situation like that. That's an obvious immediate
certainly
medical.
If somebody had a seizure and has been experiencing headaches, that warrants an evaluation and imaging. People with convulsions, we all have a threshold to have seizures. Let's say And having a seizure in your lifetime, it's not uncommon. This threshold, it's maintained by if we sleep good, if we eat good, we have a healthy lifestyle, we maintain a high threshold that prevents for us to have a seizure. People with recurrent seizures or epilepsy, they have a lower threshold. Sometimes this can be the way the brain is, and these things manifest typically when you're in younger populations as a child, and it tends to recur during their lifetime. As an adult, seizures tend to be primarily from structural abnormalities, people who suffer from strokes or bleeds, tumors. These things change the structure of the brain, and then no longer the brain can suppress abnormal activity, and then they tend to have seizures. Seizures will be then, in those cases, focal. They will start from a particular part of the brain, not so much that there's something wrong with the whole brain. And when that's the case, the seizures can as well recur. And that's the most common cause of epilepsy as an adult. So seizures can be one-time thing. If you bring down that threshold from the things of sleep, not eating well or so, trauma to the head, doesn't mean you're going to have recurrence of this seizure. So in those cases, we say they're convulsions or seizures. When they recur, that's when we call them epilepsy. Yeah. And in those cases, certainly medication is to be given to increase that threshold back to a more acceptable level.
Yeah, yeah. Getting some more questions from some of the viewers that are watching. One is sun exposure. Can that cause headaches? Can being in the sun cause something that could cause pain in the head?
Skin in the scalp and in the face, it is also perceived through the same pathways that will be stimulated to cause headaches. So you can think of that potentially if you get too much exposure to the sun, you could be experiencing headaches. Light sensitivity at times can also be a cause of headaches. There's some ocular migraines and type of specific migraine headaches that can at times be triggered by too much sun exposure, too much light. So potentially you could. You know.
Yeah, yeah. Another question that came in, Advil versus Tylenol. When you're going to the over-the-counter medications for a headache, so, you know, acetaminophen versus ibuprofen, what's your thoughts on those two drugs?
Very good. So, I mean, they're different agents. They both analgesics, you know, the non-steroidals such as Motrin, Aleve, or those agents have anti-inflammatory capabilities. So you can think of these agents have like two areas that are addressed versus Tylenol, which is only the analgesic part. I mean, fevers tend to respond mostly to Tylenol, so if there's some mild fevers with the headache, potentially you could decide to go through the Tylenol route. There's no real preference, you know, and it's primarily based on your response. If you respond to one, I will say, please, you know, do that one.
Right, right.
And if to the other, the same.
So really personal preference and what seems to work best to take away the...
Right, and that's the same logic we use for the medications we prescribe, you know. There are many, for example, particular triptans or agents for migraines, and they have some minor differences chemically. They're all in the same family, and it's not one better than the other. It's just that some people respond to one or the other, and we don't have any clear explanation, but we just have to try one after the other to see which one is going to be the one that works for you.
Sure, that makes sense, from even the over-the-counter stuff to the higher prescription drugs. In the last few minutes that we have, I'd love to have you talk a little bit about Florida Hospital's epilepsy program. You know, obviously it takes a team approach really to kind of treat these patients, a variety of different issues, from the seizures and the pain and all of that. Obviously a serious diagnosis when you get that to someone.
Right, well, in the epilepsy seizure you know, world here at Florida Hospital, there's a lot of new things that are happening, and as recent as the end of last year, they've opened new beds that can monitor patients through neurocritical situations, and that adds a significant amount of data to better care for patients. In addition to, there's some new beds for the epilepsy monitoring unit. These are at times elective admissions to evaluate people that are having either spells that we think might be seizures or spells that we know they're seizures. This is something new. It is sort of the top of what can be offered as diagnostics for people with seizures and epilepsy. I feel happy to be part of that team of physicians who participate in the reviewing those cases, so very exciting time.
Yeah, absolutely. And to have those kind of diagnostic beds there, I'm sure in a hospital setting is really helpful to your team to kind of get an idea of exactly what's going on when people are having seizures.
I mean, offers a robust tool for primary care and in general the physician community in the hospital and the surrounding areas for patients who are having situations where they think they might be seizures. And it's difficult sometimes to say clinically, listening to the story or just doing routine studies, EEG studies. And in this particular beds, we can admit people with a continuous video evaluation in addition to continuous electroencephalographic evaluation, meaning we have scalp electrodes measuring brain activity continuously. So, and this can extend from as short as 24 hours up to a week of an evaluation. So that would be, as I say again, the most you can offer for evaluations for seizures.
Yeah. We had one more quick question that I want to try and squeeze in if we can. Got a question was from someone who's had years of migraines, 25 years of migraines. Is there a certain food that can help decrease the prevalence of those migraines? Any kind of dietary advice you might have as we wrap things up?
Well, this is a bit like the medications. It's everything based on the particular individual. We do know that, for example, nitrates, these substances that are in hot dogs and other prepared foods are known triggers for headaches. At times also certain medications can be triggers for headaches. So there's some substances in diet and things that we take, including medications, that might at times be triggers for headaches. For chronic headaches, there are many alternatives, and at the end of the spectrum, we can even offer botulinum toxin injections, and that's something that can be done in addition to medications.
But certainly long-range headaches like that is something you want your medical professional to evaluate.
Correct. That's why I bring up the Botox, because when somebody has headaches this long, at times, you already went through all the other treatments available, and Botox actually provides a great response, is my experience.
Interesting, interesting. Dr. Ros-Escalante, thank you so much for all of your advice. It's been great chatting with you and answering some of the questions from the viewers. If you'd like to learn some more about head pain, you can visit www.floridahospitalneuro.com. There's lots of information on the neurology program here at the hospital, but also some information on headaches and seizures. All of that there is at that site. If you'd like to schedule an appointment with Dr. Ros-Escalante, you can do that by calling 407-303-DOCS. Just give them a call and they will set you up there. You can find out more about our upcoming web chats. If you like this one we had today, you can like us at Florida Hospital on Facebook. You can also follow us on Twitter. You can get regular updates on when the upcoming chats are going to be. Thanks again so much for watching us and participating in our chat today. We hope you're going to join us again. Bye-bye.